From Nashville Public Radio, I'm Blake Farmer, and this is Nashville. While doctors are prescribing fewer and fewer opioids, there's one that's not going away: buprenorphine. It is harder to abuse, it's far less dangerous than these synthetic street drugs, and it reduces the risk of overdosing. But it's still an opioid that is very hard to get off of. The number of Tennesseans prescribed these opioids as addiction treatment jumped by 40% in just 5 years. As we look this week at all sides of a philosophy known as harm reduction, today we focus on access to the opioids meant to get us out of the opioid crisis. After the news, this is Nashville.
Sharing news and stories from the voices of Middle Tennessee. This is Nashville. Our show is made possible by Music City Prep Clinic. This is Nashville is in service to you. So if you have an idea for the show or feedback you'd like us to hear, leave us a voice message at 615-751-2500.
Live from NPR News in Washington, I'm Lakshmi Singh. Israel is defending its airstrike targeting Hamas leaders in Qatar. This follows international condemnation and additional criticism from President Trump. NPR's Daniel Estrin reports from Tel Aviv. Hamas says none of its senior leaders was killed in the strike.
Israel's defense minister said Israel would act against its enemies in any place and warned Hamas leaders to disarm and release hostages or else they'd be killed and Gaza will be destroyed. Israel's military today struck a tower near the Gaza City seaport. Israeli ambassador to the U.S., Yechiel Leiter, told Fox News Israel would continue to target Hamas leaders because of the October 7th, 2023 attack.
Hamas terrorists are on notice. They are going to be eliminated.
Hamas says the strike came just as its leaders were meeting to discuss a U.S. ceasefire proposal for Gaza. President Trump says he's very unhappy about Israel's strike in Qatar, a U.S. ally. France and the U.K. also condemned the strike. Daniel Estrin, NPR News, Tel Aviv.
3 former senior FBI officials are suing the Trump administration, arguing they were fired for refusing to demonstrate loyalty to the president. NPR's Carrie Johnson reports the men were dismissed before they could collect retirement benefits.
The 3 officials fired last month had put in a combined 60 years of public service, helping rescue hostages, prevent terrorist attacks, and dismantle street gangs. Brian Driscoll won awards for valor and briefly led the entire FBI this year before he was dismissed by new director Kash Patel in August. The lawsuit describes Patel as struggling to please the White House and willing to dismiss anyone who angered Trump without any due process. Court papers describe internal communications that portray Patel and his deputy Dan Bongino as more interested in social media than in upholding the FBI's national security mission. Carrie Johnson, NPR News, Washington.
The administration is out with more than 100 recommendations on improving children's health. NPR's Maria Godoy says it's a follow-up to a May report that outlined what the government identified as the drivers of chronic health conditions affecting minors.
This report serves up a smorgasbord of action items that the administration says should be implemented to increase the health of children, from reinstating the presidential fitness test in schools to promoting breastfeeding. Now, I'd say a hefty portion of the recommendations deal with nutrition, research, and education for kids, but it also calls for studying the root causes of autism and for creating what it calls a new vaccine framework.
That's NPR's Maria Godoy reporting. At last check on Wall Street, the Dow is down 177 points. It's NPR News. 3 Division I men's basketball players have permanently lost their eligibility after the NCAA found the student athletes bet on their own games at San Jose State and Fresno State. The governing body for college basketball says an investigation revealed Mikel Robinson, Steven Vasquez, and Jalen Weaver also bet on each other's games or provided information that helped others to do so during the 2024-25 regular season. A New York-based nonprofit is launching a school hydroponics program in Alabama. Students in Birmingham will learn about sustainable food practices and how to combat food deserts in their communities. From member station WBHM, Noelle Anonen reports.
Welcome to the greenhouse. 8th grader Tyler Martin takes a basil seedling from a growing tower. Its roots are tangled in a sponge-like pod of peat.
And the water soaks into that, and it helps the plant grow up. So see how it's starting to grow.
Hydroponics requires only water and powdered nutrients to grow plants, no soil. Manuela Zamora of New York Sunworks says hydroponics preserves both healthy soil and water.
You use 90% less water than traditional farming. Therefore, you can really maximize, the growth of certain types of plants and vegetables.
She says the project will produce thousands of pounds of food for the local community. For NPR News, I'm Noelle Annanen in Birmingham.
The Dow's off 174, the S&P's gained 30, and the Nasdaq is up 67 points. I'm Lakshmi Singh, NPR News, in Washington.
Support for NPR comes from NPR stations. Other contributors include Charles Schwab, offering investors choices like full-service wealth management, advice, investing, and trading on Thinkorswim. Learn more at schwab.com. And from the Doris Duke Foundation.
Funding for This Is Nashville comes from you, our listeners. And Amazon, proud sponsor of WPLN's daily show, This Is Nashville, engaging our differences so we can discover our unity. More on Amazon's community work at aboutamazon.com.
I'm Blake Farmer, and this is Nashville. We're focused on two little words that may not have meant a lot to you before the start of this week if you listen most days. Harm reduction. Could be a lot of things. Anything that helps us do something dangerous more safely. This week, Nina Cardona had a lovely essay on her Nash Villager podcast, which I highly recommend, looking back at the history of how safety features like seatbelts got into our cars. I mean, if you can believe it, there was a time when people argued against seatbelt mandates. Now our cars have all these features that are purely intended to avoid the what-ifs that come along with driving a ton of metal 70 miles an hour. So for our purposes today, this week, harm reduction is referring to drug use. How to help people do something risky like using hard drugs more safely without necessarily getting them to stop. On Monday, we followed a woman flouting the laws and passing out clean syringes based on her conviction that she's saving lives. On Tuesday, we looked closely at harm reduction that has been approved in Tennessee, like distributing overdose reversal medication or fentanyl test strips, even some syringe exchange programs within fairly tight regulations. And another form of harm reduction is known as medication-assisted treatment, although it is certainly more on the treatment side of things. And right now, it is the standard of care for someone in opioid addiction. They start taking a dose of another opioid, like methadone or buprenorphine, to help curb their cravings. Joining us to talk about MAT, as it's known, is Dr. Leslie Cole. She runs her own addiction clinic in Robertson County. And Josh Draper, a project coordinator with the Sumner Prevention Coalition and who has his own experience with these medications. Thank you both for being here.
Thank you for having us.
Thank you so much.
And quick note, we are streaming live video at youtube.com/@WPLN if you'd like to join the conversation visually. Dr. Cole, tell us about the patients you work with. How did they end up in your clinic?
Okay. I work at Pathway Healthcare, which has multiple sites. How they end up in our clinic is a couple of ways. They have struggled with opiates, fentanyl, different addictions to different opioids. They may have bought Suboxone off the street and found that it stopped their cravings, and they were able to start getting a job, getting their life back. We may get a referral from a rehab facility, or people Google us.
Yeah. So you're help me understand somebody maybe that you've just started working with in the last couple weeks. Like, what does their story look like? That they have tried a lot of other things. They've tried rehab. They've tried abstinence and come to you, or this is their first stop?
Yeah. Okay. So almost everyone. I don't know anyone who hasn't tried abstinence. Mm-hmm. All of them try abstinence first, and then they relapse.
Just cold turkey.
So
I'm gonna
turkey.
quit.
I'm gonna just completely get off of it. Mm-hmm. And so I don't know anyone who has come to our clinic that hasn't tried that first. Mm-hmm. They frequently, like I can think of a bunch of people who, a friend, like they get addicted to Lortabs.
which
Percocet, an opioid,
painkiller, yeah.
Opanas, things, and they're buying them on the street. And a lot of times those are fake. They have fentanyl. The tolerance gets worse and worse and worse. They can then get totally dependent on it, where it is completely taken over every thought they have.
Yeah, and it's no more about treating pain. It's about not having withdrawals and
having withdrawal.
Yeah.
Not having withdrawal.
Can you tell me why are we talking so much about buprenorphine these days and not methadone? Which I think for decades people talked about methadone clinics. Why is buprenorphine kind of it seems the preferred route these days?
Well, methadone, yeah, okay. So methadone is a full agonist, meaning it acts like heroin. It acts like all the opioids. Buprenorphine is a partial agonist, meaning it doesn't give you the full euphoric effect. Most people. It does not give them the full euphoric effect. It doesn't give the nodding out, the sleeping, the respiratory depression like the full opioids do. So buprenorphine ends up being, and also buprenorphine has got such a strong affinity for the receptors, the places that the opioid needs to connect to in the body. It's got such a good affinity, it can bounce off other opioids. Like if someone has buprenorphine and fentanyl, the buprenorphine can bounce that off of the receptors.
Because it has some of the overdose reversal drug in it, correct? The naloxone, is that?
Yeah, there's a combo, buprenorphine and naloxone. And naloxone is an opioid antagonist, blocks.
Right.
But buprenorphine is the agonist. So it's a combo, but both of them can protect the cells, protect the receptors from the other opioids. It's so strong. The affinity is so strong and good.
Yeah. Well, should we have opened this can of worms without the pharmacist in the room for the show? But we've got a pharmacist in the next segment. Josh, I want to hop to you, which, of course, you have your own pharmacy experience as a pharmacy technician, right?
I do, unfortunately, but also fortunately, because I'm here today. So
yeah,
yes, I actually. So I'm in recovery. I at one point used buprenorphine, both in Subutex form, Suboxone form, but also methadone recreationally.
Yeah.
And while it may not, I know you said it may not. Sorry, let me go back just to my background real quick. I started off working in a pharmacy when I was 18, 19 years old. And at one point, I don't remember exactly how it happened, but it became desirable to start taking pills from work. And so for me, it started off with really Xanax first, or alprazolam, and benzodiazepine. Right. But eventually it became hydrocodone. And then that became stronger opiates, and stronger and stronger and stronger. And somewhere in there, Suboxone was released, and I got to the point where I would prefer it over a lot of things. Methadone, I prefer it over a lot of things. And I can't speak for everybody else. I can only speak. This is, and by the way, any opinion I have is my own. It's not the coalition's. Yeah. It's but I mean, I could show you guys a picture right now of this. This was a result of Suboxone.
All right, I'm looking at. I see a pretty bad car wreck. Is what I'm looking at.
And that was a result of nodding out on Suboxone.
Yeah.
And so I have a little bit of a different experience with it. And I'm not completely advocating against it. Yeah. I think maybe prolonged use of it can be damaging. And I will say this about the coalition. Our mission is, particularly for Sumner County, we envision a thriving and healthy community free from substance abuse. And it's hard for me to get over the fact of people who use Suboxone or any type of opioid, synthetic or otherwise, regularly. That's not recovery to me.
Well, and I know that's a divisive thought in the recovery community. I want to get at that this hour. If you're just joining us, I'm Blake Farmer. This is Nashville, and we continue our week on harm reduction with this hour talking about the opioid that is often thought that it will end the opioid crisis. Dr. Cole, talk to me about this. Is abstinence the goal with most of your patients at some point, that you would wean off of Suboxone?
Well, I talk to every single patient about that.
Yeah.
I say, hey, we will taper it when you are ready, if you're ready.
Yeah.
I have a huge bell curve of patients, some who say, I am never getting off of this ever.
Yeah.
You know, they've struggled so long and so hard and had so many relapses. I'm taking Suboxone the rest of my life. And then
they're saying because I know a relapse could be deadly every time.
Yeah, because they've overdosed. They've been in the hospital. They've had to be Narcaned over and over.
Yeah.
Yeah. So that they, so I don't want to die. I will be on Suboxone the rest of my life. I'm able to keep a job. I've got my family. I've got my kids. I've got, I'm doing well at work.
Mm-hmm.
So then I've got a bell curve of people who are, I want off of this. And so we totally do a tapering plan for them. And so I've had a lot of people actually taper off. And then I've had some people we've tapered off who then have cravings again. And to prevent relapse, they come back in and we restart Suboxone with the idea of we will see what you feel like you need.
Yeah.
Because, the cravings can just bypass the prefrontal cortex.
Yeah. Can you talk about your experience, Josh, in tapering off of, obviously, as you were talking about, this very drug we're talking about is something that you abused, but then you also have gotten off of it. How does it compare with getting off of other opioids?
In my experience, methadone in particular, but Suboxone a close second, those were the worst withdrawal symptoms I ever had. They were worse than any other, and I took other opioids. I mean, oxycodone, oxymorphone, or Opanas, Dilaudid. I mean, the hardest prescription opioids you can get. I did not experience the withdrawal symptoms with those as I did with Suboxone or methadone.
Can you talk about withdrawal? Because I'm not saying I have a full understanding of it, but I think it took a while for me to understand that, like, withdrawal is not like, oh yeah, it kind of stinks to be not taking that. That it's like full body sickness, or like what was it like for you?
It is, but I've also, and it is. It's a full. I mean, you feel like you have the flu. You're sick to your stomach. Headaches.
Yeah.
It's a horrible fog. But I also have it to compare to that. I also abused benzodiazepines for a long time.
Yeah.
And physiologically, those are far worse. You're not going to die coming off of an opioid.
Mm-hmm.
You're just not. It doesn't happen. You might coming off of a benzodiazepine, or you might if you're withdrawing from alcohol.
Mm-hmm.
And I guess that's my question. Why don't we treat opioid addiction like we do alcohol addiction? Or like we do stimulant addiction? There's no medication-assisted treatment for them. I mean, I know Vivitrol is sometimes used for alcohol withdrawal, but there's no stepping down. I mean, think about this. Like, if you have a hard liquor problem and you're addicted to, you don't go to a doctor and they prescribe you beer.
Mm-hmm. Yeah, or say like just cut back. I mean, I guess there probably are folks who talk about cutting back. I mean, you're an addiction physician. Let's say somebody comes in with something else, alcohol.
Mm-hmm.
What's the standard of care at the moment?
Standard of care, you're right. Alcohol, coming off alcohol, you can die. So it's better to come off alcohol inpatient.
I see.
So, but they come to me then. They're off the alcohol.
Because they've already had an inpatient program. Somebody saw them through the withdrawing period.
Yes, because you can die, you can seize, all sorts of things. So there are medications that help with cravings, Vivitrol, naltrexone, gabapentin. There's this whole group of medications, and we do give those medicines for people.
Mm-hmm.
So we do. I do have patients who I'm giving acamprosate, naltrexone, gabapentin.
But can you talk about this point of why we do this differently? Is it because using drugs on the street is so dangerous right now that this is just preferred in almost every way?
Okay, so the fact that it's a partial agonist, if we had a partial agonist for alcohol, if we had a partial agonist for methamphetamine, for cocaine, for benzos, we would have the same situation going on. If we had something that was safe and hit that craving, because like for a benzo craving is a benzo craving.
It's different than opioids.
Yeah,
okay.
There are things that things don't work. An alcohol craving is an alcohol craving. Meth, cocaine, they're all slightly different. They all hit different receptors.
Yeah.
So
it's my opinion that this is a very profitable industry for pharmaceutical companies in particular. I mean, Indivior, the company that came out with Suboxone, had to settle out of court for $1.4 billion because of their illegal marketing strategies that they went to providers with.
Yeah.
And we're saying stuff like, while it may be a partial agonist, it's, because of that, it's not as addictive as, say, methadone. It's not as addictive as this. And they had to pay out of court because of that.
Well, we certainly, and boy, looking back at the way that opioids were sold, we've certainly looked back and seen, wow, physicians were sold a bill of goods in a lot of ways about what was addictive and what was not. Josh, finish your thought.
No, that was it. I just I say this stuff out of love for people. I truly have compassion for people that are living even in addiction to medication assisted treatment, because you're not able to be your full self.
Yeah.
It's just a little something holding you back.
Well, and we, we've got some heads shaking in the room, and we'll as you can imagine, Dr. Cole has some thoughts. We're going to talk philosophically about this at the end of the hour, but we need to take our first break. Josh, thank you so much for sharing your thoughts here. And when we come back, we're going to talk about some of the barriers to getting on this medication to treat opioid addiction. Many experts want to take treatment on the road, making it far more accessible, but that is a real challenge in Tennessee and elsewhere. Stay with us. This is Nashville.
Funding for This Is Nashville comes from you, our listeners. And Second Harvest. 1 in 7 Tennesseans faces hunger, but when others take one action to help those in need, that's when progress is made. That's the power of one. SecondHarvestMidTN.org. And Community Foundation of Middle Tennessee, working to help donors make more possible through the power of community giving. More at CFMT.org. And Wildwood Resort and Marina on Cordell Hall Lake, offering corporate and nonprofit retreats, getaways, and celebrations. 1 hour east of Nashville, year-round. More at visitwildwood.com.
I'm Scott Tong. The post-war world order is eroding. One historian says it's like an old house with crumbling foundations.
I think we're getting a nationalism which looks for enemies. Nations readier to go to war, more talk of war than we've seen for quite a while.
How a world order ends, next time on Here and Now.
This afternoon at 1 on 90.3 WPLN News.
I'm Blake Farmer, and this is Nashville. This week we're talking about the tactics being used to get us out of the opioid crisis. Many of them are considered harm reduction. They're not always leading someone to drug treatment. Sometimes it's just helping them use drugs more safely to reduce transmission of disease or a deadly overdose. Today we're focused on a form of harm reduction that is certainly part of treatment. It's medication, like methadone or buprenorphine, as we've been talking about. They're opioids that are safer than anything someone could buy on the street, and they have become the standard of care, but even though their effectiveness is widely accepted, they remain highly regulated because they are still narcotics. Belmont University announced this summer the launch of a harm reduction clinic on wheels. The idea is for it to lead people to medication-assisted treatment, but as we'll hear, mobilizing MAT, as it's known, can be a challenge. Tracy Frame's a pharmacist and Belmont professor who's co-director of the Flourish Mobile Clinic, which is up and running with one unit, has another in the works. Welcome to This is Nashville.
Thank you.
And Chap Cuthbert is a peer support specialist. He's worked in overdose prevention in Middle Tennessee, currently with the Mental Health Co-op, our neighbors here in Metro Center. And he's working with the Belmont Clinic to lead people into their medication-assisted treatment program at the Mental Health Co-op. Welcome.
Thank you.
So quick note, we are streaming video at youtube.com/@WPLN. And you're welcome to make a comment there if you're watching. We hear from Ron, who's at A Better Way in Memphis. Great panel today. Please discuss financial barriers for uninsured clients who have poor health outcomes. We'll hopefully get to that later in the hour. So Tracy, your mobile harm reduction unit is already making the rounds. Can you tell us about the kind of folks you're helping at this point? Who are you seeing when you're on the street?
Yeah, absolutely. So we applied for opioid abatement funding, and so that's what's kind of funding our mobile unit. And so we're extremely grateful for that.
Yeah, big grant. What, $6 million over 3 years?
Yeah, $6.4 million over 3 years. And so we are getting it off the ground right now, and we have been meeting with organizations across the city. But our primary population that we're focusing on is the unhoused and under-resourced individual population, so transitional living population.
Yeah, and the idea is to take what to them?
Yeah, so we are taking a lot of things to them. So the hope is that actually it's an interprofessional medical group, and so it's not just like medical care as people typically think, but we are also bringing mental health, counseling. We're going to be bringing therapy like occupational therapy and physical therapy and social work services and so forth. And so we are bringing in obviously the medical piece, but also this therapy and clinical piece side.
So what makes it challenging? Because medication-assisted treatment that we've been talking about, of prescribing something like buprenorphine, or known often as Suboxone, why is that harder than just converting an RV into an exam room and taking it on the road?
Why is it harder?
Well, in other words, it's more than just prescribing, right? There's kind of this sort of connection that you need to build with a patient.
Yes. Yeah. I'm a pharmacist, obviously, as you've already stated, and I would say MAT and the medications used for MAT are wonderful, and I think they save lives. But I think there's a huge piece of the whole person care that we really have to talk about. And I think that a lot of times we miss it if we just talk about the medication piece. And so if we are really helping people get in recovery, I think there's so many pieces, right, that need to also be involved with that. Like we think about just family, like if they've lost their children or lost a job or have no transportation, they don't have a license, like all of these pieces make it difficult to do anything, right? And so if we are just treating addiction with medication and not really thinking about that whole person and trying to really get them support in so many different areas, social support, emotional support, spiritual support, all of these areas, then I think we're not going to see success.
So, and at the moment, someone doesn't come in and get a prescription for Suboxone at your mobile unit, correct?
Correct. Yes. Yeah. We legally, by law in Tennessee, you cannot dispense MAT off of mobile units at this point.
Right. So in other words, to really have mobile MAT that's really, you can actually get the medication in hand from there, state law would have to change.
Absolutely.
Chap, Mental Health Co-op's partnering with Belmont here, and it sounds like as a bridge to that, if the law does change at some point, you all are kind of trying to get a warm handoff. What does that look like if there's going to be a patient come in who's ready to, start medication-assisted treatment?
Yeah, so, we're grateful that Belmont has asked us to partner with them. And kind of how it's going to work is once the clinic is at a certain location, as we're seeing patients, as they get triaged, maybe they need wound care, maybe they need, other kind of things, primary care. Yeah. If we identify somebody that, substance abuse may be an issue with them, then we're going to have peer support through Mental Health Co-op, and then most likely an intake counselor that can kind of get an idea of just kind of their background, their willingness for treatment, what's been going on. We'll be able to do a lot of that kind of things right there at the clinic, meeting people where they're at. And then we'll be able to, see if they're a right candidate, for medically assisted therapy, which we will have a warm handoff at our brick and mortar, which is located here in Metro Center.
Yeah. And can you stop for just a second on wound care? Because that gets brought up in harm reduction sometimes. And is this all about, if you're talking about somebody who's in the depths of addiction, an IV drug user, there are going to be infected wounds often? Like, why is treating those considered, harm reduction?
Yeah. So if somebody's an IV user, they're at risk of needle infections at the site. But what we're also seeing is xylazine, which is a drug that's being added to the drug supply.
Yeah. It's like a horse tranquilizer or something, right?
It's a horse tranquilizer, and it potentiates the effects of fentanyl, and also kind of prolongs its use. So it's real popular. But one of the things we're seeing...
In other words, people want it. It's not like they're being... Yeah, okay.
Yeah. And one of the things we're seeing with xylazine is it also has a tendency to cause wounds that show up not necessarily around the injection site.
Oh, really?
It can be in the lower extremities, and we're seeing that very often, particularly in the unhoused population.
Oh, that's right. There was in fact, it came up yesterday, and I was talking about something about the way it affects the capillaries or something so people don't heal from wounds. Wow.
Right. And the problem is sometimes folks don't really realize it's the drug that's causing it. They think it's something else. So these kind of wounds can get really, dangerous in a quick period of time where, we're seeing people that are losing, muscle and skin and sometimes up to amputation. So,
wow. Yeah. And how does one get from getting a wound treated to having this, what seems like a much bigger decision moment to say, I need to begin treatment?
Yeah, and that sometimes, speaking from personal experience, sometimes, a situation where it's brought to your attention that, hey, drug use is doing this. Drug use is leading to overdoses. So some sort of crisis sometimes is that opening, where somebody might say, hey, I want some help.
Peer support is what you do, and peer meaning like you've been there. Can you talk about what got you, what pushed you over the edge?
My bottom is kind of what we kind of refer to that as I got arrested.
Yeah.
In the segment beforehand, I'm a pharmacist.
Yeah.
And I was stealing drugs from my pharmacy.
Yeah.
And the arrest of that was finally a bottom for me to say, I really got a problem here that needs to be addressed.
So is the point that there's almost what you can do in like a mobile clinic here is sort of show them like the things that we're treating here today are a result of the risky behavior, and that could be the moment that you connect them?
Absolutely.
So, Tracy, can you talk about why it's important to act quickly in that moment?
Yeah. When we talk about addiction and people that really want treatment, it's really important that we get them to treatment as soon as possible, because what happens is people have cravings and withdrawal, and then they're going to be back out on the street if we don't get them into treatment when they want treatment. And so that's a really big area that we hope to focus on with the unit, is that if people want treatment, and that's why we're excited about our partnership with Mental Health Cooperative, because they do have same-day appointments and they have detox beds and everything that we can kind of get patients connected into as quickly as possible. And so it's really, really important just to prevent them from going back out.
Yeah. Why have states been slow to allow dispensing of medication like Suboxone, like in a mobile unit like this? Why are they hesitant?
I think there's concern for safety. Obviously, it's an opioid on a mobile unit, so safety risk goes up. But I also think it just goes back to people are concerned about Suboxone in general, or buprenorphine in general, right? There's always been a concern of misuse, of selling it on the streets.
Well, it is sold on the street. Why?
It is. So typically,
because when you hear someone say like an addiction medication's being sold on the street, explain, please.
Yeah. So typically, most studies actually are showing that it's sold on the street because it helps people that are active users of opioids. It helps them with withdrawal. It helps them when they have a lapse in care, so they're not able to get to their physician or provider to get their buprenorphine or whatever they were taking. And then it really just helps with cravings. And so it's in those kind of in-between periods. But it's really typically at least studies that we're seeing are showing that typically people are not using it, that people that are opioid users, so not a high school student that wants to try it out, right? But people that are actively using fentanyl and stuff, it's really used for those reasons.
This is just getting them through to not go into withdrawal until they can get maybe what they really are wanting.
And that's a high percentage. Our studies are showing of that's really like people are not really abusing it on the streets. They're using it for these reasons.
Yeah. Chap, talk to me about like the lives you've seen change when someone starts MAT in kind of a controlled setting.
It's miraculous, and it's Suboxone isn't necessary for everybody, but certainly folks that are really at real high risk of particularly using very, very potent opiates that we're seeing with fentanyl, it's very, very useful. And I've seen somebody go from somebody that was using every day, ODing multiple times, to finally getting to a year of sobriety, and then making that decision, hey, is it something that, I might need to start tapering off? But I've seen miraculous things. It's actually, people live. And also, one of the things about MAT, it's not necessarily, it's not a medication we give somebody and then all of a sudden they're cured.
Yeah.
There's many other wraparound things that are very important to continue, like counseling, peer support, case management, so certain things that we kind of wrap around somebody while they're, in medically assisted therapy. It's not just, hey, you go to the pharmacy, you get your medicine, you go home, and then you go on. There's many other things that kind of go around that help that person be successful.
And last thing, Chap, is there enough access? I mean, you all are spinning up this mobile unit. Is that just because it's not a matter of having enough people who will prescribe it, but actually getting close enough to the people who need it that it makes it easy?
Yes. And that's one of the things that we're really excited about with the Flourish Clinic is we're going to be able to go to areas where folks maybe not will have transportation to get to a brick and mortar. And then once they're linked with Mental Health Co-op, we're going to be able to provide transportation, all kinds of things around that. So, getting them in and then getting exposed to our other services, psychiatric care, physical health, and all that kind of continuum of care is what we're looking for.
Well, Chap, thank you for joining us and sharing us your personal experience and your professional experience here. And Tracy's going to stay with us for the last segment. But before we go into the break, I want to go listen to this story from our managing editor, Tasha A.F. Limley. We've been talking about why mobile MAT could help in the Nashville area, but I mean, in rural Tennessee, it's often the only chance someone has. She starts her story on the porch of an MAT patient who's been doing gymnastics to keep her prescription coming.
Christine Burris lives in Madisonville. It's a rural area about an hour south of Knoxville in East Tennessee.
It's a great place to live. Some of the neighbors are nosy and, cause a little grief sometimes, but that's everywhere, I guess.
She said she was born without a hip joint. So doctors had made her one, and after having 6 children of her own, she was experiencing quite a lot of pain. So she got prescriptions for Percocet and Opana, which is a powerful narcotic currently known as oxymorphone.
I was always down. I couldn't get up. I couldn't take care of my family. I couldn't take care of myself. But when I would hurt, I didn't realize that was way too strong for me.
One day back in the early 2000s, she was visiting family out of state and had forgotten to bring her meds. And then her cousin says, I got a pill right here, and it's not a pain pill. He said Suboxone basically gets you off of pain pills.
So I did. I bought one of them, and I broke it in a bunch of little bitty pieces like quarters. And then I took one little quarter, and I was good the whole day. I didn't hurt. I wasn't sick. And it lasted me all the way up in the next day. And I was like, that's a miracle drug.
She says she came home, fired her pain clinic, and tried to find a Suboxone doctor with no luck. So for years, she just kept buying enough Suboxone here and there from different people to ration and get by. She says she could get each one for $7 or $8, and 5 would last her nearly a month. Then a neighbor turns her on to an addiction doctor.
Dr. Yao Ochere Bowatin. I am a physician, mostly working in hospital as a hospitalist and also doing addiction medicine. I got interested seeing so many withdrawals and people coming at the tail end to the hospital because of overdose.
Dr. Boateng sees a small amount of rural addiction patients remotely via telehealth, and he takes on Christine. She's able to meet with him through her phone.
He is great. I mean, I like the questions that he asks. He wants to know about if your appetite's okay, and if you're resting okay, and if your medicine works for you good. And I mean, he's got good questions that he needs to know the answer to. He absolutely cares.
As good as it might feel for Christine and others like her to have consistent and legal access to Suboxone, there's still quite a few steps to getting medication. For one, in the first month of treatment, Tennessee regulations require doctors to only prescribe 1 week of medication at a time. And during that time, they must return for weekly urine drug screens. That's to make sure they are taking the Suboxone, not overtaking it, and not using something else along with it. Christine doesn't have a working car, and she's the primary caretaker for her disabled sister. Still, she does have people in her world that can help her out.
So I've got it good all the way around with this.
So you're saying you've got it good all the way around?
With this one I do, yes.
But this is also, you have a bunch of steps to try to just get one prescription.
Yeah.
You need someone to pick you up and take you to your family care doctor, and you do your urine test, and then you upload paperwork to Dr. Boateng.
Mm-hmm.
Then you get on the phone with him. He asks you some good questions about how you're feeling, how it's working for you. Then he calls in the prescription, 45 minutes away. Then you have another family member who needs to pick it up and bring it to you. That's a lot.
It is a lot. But they love me and they help me. You know, they will help me. They do.
Christine's not the only rural Tennessean struggling for health care access. So Dr. Boateng, he's hoping to start a mobile medical van, cutting out some of the steps Christine and her neighbors have to do to take care of themselves.
People have to understand that the opioid crisis is real. It doesn't seem to be going away anytime soon. So if we are able to reach them where they live, it becomes more easier for them to be compliant and follow up with their treatment.
Oh, that'd be so awesome. It would. I would love it.
For WPLN News, I'm Tasha A.F. Lemley.
We need to take one last break, and when we return, we'll talk through the thorny issue of, whether medication-assisted treatment is just trading one opioid for another. Stay with us. This is Nashville.
Funding for This Is Nashville comes from you, our listeners. And We Go Transit, working to make Titans game day travel easier with local bus service drop-offs near Nissan Stadium and new express bus service from Sumner County and Bellevue. WeGoTransit.com. And Age Well Middle Tennessee, offering Elder Care Coach, providing online resources and phone consultations designed to help families navigate care for aging loved ones and to assist employers supporting caregiving employees. More at eldercarecoach.org.
WPLN is giving you a chance to win tickets to see your favorite artists in concert and explore new music and events. Visit the WPLN giveaway page at wpln.org/giveaways.
So it happened. The federal funding that supported the entire public broadcasting system is gone. I'm Holly Kernan, president of Nashville Public Radio, and I'm here to say that's okay. In fact, there's even a silver lining, and it's this. We are now completely independent. The criticism that we should not get federal funding is now moot. We depend on you, our listeners, our members, our community. So join us. Let's make sure Nashville has the public radio we deserve.
I'm Blake Farmer, and this is Nashville. We're focused on the primary way we're expecting to get out of the opioid crisis, and in many cases, it will require getting people with drug dependence on another opioid, a much safer much harder to abuse medication, but still hard to get off of, if ever. Dr. Leslie Cole, who has her own MAT clinic, and pharmacist Tracy Frame of Belmont's Mobile MAT Project are with us to talk through some of this. And a reminder, we are streaming video at youtube.com/@WPLN. It's an easy way to weigh in on the conversation. We're going to be taking your calls in our episode tomorrow. But for today, you can leave comments at the YouTube stream there, youtube.com/@WPLN. All right, so Tracy, as a pharmacist, yes. Have your views on medication-assisted treatment when it comes to the opioid crisis kind of evolved over time?
Absolutely. I would say, coming out of pharmacy school almost 20 years ago, not really understanding addiction, I think I would have had the opinion like this, I don't know if this is helpful. Is it just trading one drug for another?
Mm-hmm.
But I would say, having worked in recovery for the past almost 10 years, and then my husband is actually in recovery himself, I truly believe that it can save lives.
Is it part of his story?
It actually is not. He is one of those people that quit cold turkey and somehow succeeded with a lot of support system around him. Spiritually, he loves Jesus, and he really found Jesus in that moment.
He's a pastor, right?
He is a pastor here in East Nashville, yes. And so he has an incredible story for another time. But I would say, working with women and kind of what we've already talked about, there's just so many pieces to addiction, and it's not just the medications, but it's just, it really is like when we think about trauma and what people have endured and what they don't have. Typically when people come to get treatment, they've lost everything, including the ability to drive, to get a job, to have family that's supporting them. And so I think a lot of times that it requires a medication to help them with those cravings and with those withdrawals, right? And so they can get back on their feet, and they can start to have those resources around them to be able to be successful and have a better life, right? And be able just to be around people that they love again. And I think.
Well, the tendency, though, is people think the experience that I've seen, that's how it should be done. Dr. Cole, do you run into that people, if it worked for them, they think it should work for everybody?
Yes.
Like the cold turkey thing.
Yeah, absolutely. Yeah. So people, I think sometimes whatever they think exactly worked for them, everyone has got to do the same thing. But as the physician on the other side, seeing hundreds, maybe thousands at this point, of people, I see a huge bell curve of people where some people just have cravings like nobody's business, and other people can get to that cold turkey thing and not ever need anything again.
Yeah.
I've seen it. I've seen all that big bell curve.
Well, what to folks who are trying to think, well, there's really only one real recovery, and that is total abstinence from opioids. If that's kind of been the issue, what do you say to them to help them see it your way?
To people who say what now?
Yeah, who think abstinence is sort of the only true recovery, is working your way to all the way that there's no drugs part of the equation.
Well, okay, so one thing that I would say is I think because of the awful stigma associated with medically assisted treatment, people don't know all their friends, family, and neighbors who are on
I think
buprenorphine.
You're right. Yeah.
And so
because they're not advertising this.
No.
But they're able to live a very normal life. You wouldn't know.
Oh, normal and totally successful.
Yeah.
I have got people who have gone back to school, people who graduated nursing school like this month, people about to graduate nursing school. I've got people who've got huge businesses with tons of employees. I've got people who own stores in several cities, and they are buying houses, doing well, taking their families on cruises, buying cars for their children. I mean, their lives are so they're blossoming and successful and healthy. They're going to church, but they're not going to just tell, hey, I have an announcement to all my employees. I'm on Suboxone. No, they don't do stuff like that.
Yeah.
Because there's a lot of stigma.
Yeah. But it sounds like it wouldn't hurt for people to be a little more open about it, and then one could see, that there are highly successful people who are using this to overcome their addiction.
Yes, and there are some who, I've got quite a few patients who've ended up being very open about being on Suboxone or buprenorphine and how they've done well. People who, are regional managers for restaurants who now tell their employees, and they can spot their employees who are struggling.
Yeah.
So, yeah.
What does it look like if a patient, I guess what I'm wondering is, there are folks who would advocate that buprenorphine, this sort of medication behind all this, was far more widely available. But could there be harm in this being, so available that it's almost over the counter?
Do you want my personal opinion?
Well, I guess that's the only reason you're here.
I think it should be so readily available.
Yeah.
I have, there is the rare person who says, at first I experienced some euphoria.
Yeah.
But the people that I see day after day after day after day are taking their medication. We know they're taking their medication because of urine drug screens, observed urine drug screens, oral swabs. We see, they've got great levels of buprenorphine, and they are so calm and sane. They're not nodding off.
Yeah.
They're not having car wrecks.
Yeah.
They're not out, craving and jonesing and having their whole brain bypassed by where's my next.
Because that's the mindset is that it's the only thing you can think about at some point.
It is the only thing.
Yeah.
It is the only thing. And so you lose your job. You can't take care of yourself. You can't pay your bills. You can't. Everything falls apart and falls away.
Yeah. If you're just tuning in, I'm Blake Farmer. This is Nashville. We're wrapping up our hour. I'm talking about medication-assisted treatment. All week we've been talking about various forms of harm reduction. Obviously, this is really on the treatment end of things. I'm interested, and I'm not sure if this is a question for Tracy or for Leslie here, but what does the counseling look like that goes along with Suboxone use?
Let me start? Yeah.
She's deferring to you, Leslie.
Okay,
yes.
yeah. Go for it. All right, so we, in our clinic, we have someone have counseling every time they come into the clinic. So
And
I
it's with
counsel.
you. It's not like some other special counselor. It's their physician, you.
Both.
Okay.
We do both. We have a special counselor. Sometimes they go to group counseling. Sometimes, and then I will counsel them on different things.
I see.
But yeah, on everything. I mean, the counseling. So, at first the counseling needs to be things like avoiding people, place, and things, or hey, where can you get your license back? Hey, where can you get transportation? But years into it, it may be a totally different counseling situation.
Yeah, but that you're trying to help them navigate life and not wind up back where they don't show up for their appointment and all of a sudden you're very concerned.
Right, and I will say between 6 months and 2 years, they are navigating life.
I see.
They are doing so well.
The counseling's almost more like catching up or something.
Well, it can be, but there's always a lot that can be talked about with patients.
Yeah.
So,
Tracy, your husband, I know his church really has attracted a lot of people who are in recovery, and I can understand why. How does this discussion go over there? Because I know for instance, like the sort of AA communities, whether you're on MAT is a pretty touchy subject.
Yeah, it's a definitely a very controversial topic, I would say, especially among the recovery community. And I would say we have friends actually that kind of go both directions.
Yeah.
But I will say when I talk about this, I always go back to my husband, and I think if he would have needed MAT, would I want him to have it MAT? And I think if all of us really thought about it, and if it's something that can save someone we love's life, we're all going to say yes to it. And so I think a lot of times when people really need this straight out of the gate, when they are new in recovery, I truly believe that it can be really helpful. Now, all that being said, I think there are discussions that need to be had with physicians and providers that are prescribing it on when maybe is a good time to taper, maybe never to taper, right? We don't know. I think that's the hard part. A lot of us want to make assumptions on what we know about people in their life, and we don't know. Yeah. And so I think it's really important for us to trust the providers that are sitting down with these patients and counselors and with them every single week to say, like, hey, everything's great in your life again. It might be a really good idea to talk about tapering down, right? And so I think all of that's really, really important when we talk about it. But yes, I would say it's a constant conversation. I've actually seen people that were very resistant start to come alongside because they're watching their friends die as well. And so at what point do we put someone's life, do we say like, okay, let's let them continue to use fentanyl because we just don't agree with buprenorphine personally, right? So I think, again, it goes back to a personal choice and having that conversation and talking about the risk and benefit of the medication and what we're going to start patients on. But I think that's really important to think through.
As we wrap up here, Dr. Cole, do you feel like you have the trust of people? Do folks trust that doctors are making the best individualized decisions for patients who are struggling with addiction?
Doctors as a whole?
Well, I don't know.
I don't know.
I guess what I'm saying is,
me.
Do you wear on your sleeve that you are an addiction medicine? Or is it even, do people have judgments about that?
Oh, yeah. I get kind of the skanky eye as a point of, oh, okay. What does that mean? But who cares?
Yeah.
You know? I think most of my patients end up trusting me because I am believing them. I think that's an important piece, is getting to a place where you have someone who can believe you, because part of the struggle that happens with these use disorders is not being able to tell the truth. And when you start being able to tell the truth and someone receives you, it's healing.
A beautiful place to land. Thank you, Dr. Leslie Cole, to pharmacist Tracy Frame for providing your expertise on this very important topic. Thank you. This is Nashville is a production of Nashville Public Radio. Today's episode was directed by Tasha A.F. Limley. Our board operator is Liv Lombardi. The masterminds behind our theme music are LaRange and Namir Blade. Listen back at thisisnashville.org or wherever you get good podcasts. Yesterday's show was on sanctioned harm reduction in Tennessee, needle exchange, naloxone distribution. Monday's show, a very difficult piece about a woman named Miriam Field and her efforts to provide life-saving harm reduction, disregarding the regulations. And tomorrow's going to be your turn to talk. We've fed you a lot on this topic. We'll have former Nashville Mayor Megan Barry, who lost her son to an overdose, and another addiction doctor to take your questions, hear your comments on how addiction has affected your circles. The conversation does not end here. You can comment, tell us what you want to hear on the show by leaving us a message at 615-751-2500. You can also find us on Blue Sky and Instagram and X at This Is Nashville. This is Nashville. I'm Blake Farmer. Go in peace.
Students can chart their new intellectual and career journey through Vanderbilt's Master of Liberal Arts and Science program, which is designed to be ideal for working professionals and lifelong learners. MLAS offers flexible scheduling and a variety of evening classes taught by Vanderbilt's renowned faculty in the fine and creative arts, history, literature and creative writing, and the social sciences. Now accepting applications for the spring term. Details at vanderbilt.edu/MLAS.
This is 90.3 WPLN,
Nashville Public Radio,
and 91.7 WHRS Cookeville.
Nashville's home for Morning Edition and NPR News.
WPLN.org is where you can find more from WPLN News, including the Nash Villager, your human-powered newsletter and podcast, exploring Nashville news and history. Subscribe to both at WPLN.org.